Providing interactive video and DVD media to teach dentists the didactic coursework prior to our hands-on workshops. And to this day, it is unique in dental education. After many years of giving lab courses in our teaching center in Santa Barbara and in dental schools around the world, we've designed this home study course for those who want to take their first cut through my endodontic treatment methods without the expense and hassle of travel.
Every access procedure begins with rubber dam isolation. To do an endodontic procedure without a rubber dam is practicing below the standard of care. Isolation should not be a difficult, time-consuming event. If you have the right setup, this should take less than a minute. Only 5 rubber dam clamps are needed for virtually any tooth you will need to isolate. The number 9 clamp is designed for anterior teeth, difficult premolars, and previously prepared molars. You'll notice the serrated clamp jaws in most of these clamps, making their purchase on the tooth structure more secure. The number 1 clamp is very strong. It's the ideal clamp for most premolars. The next 2 clamps are a pair, the 12A and 13A. These are designed for upper molars. You can see one jaw narrower for the palatal side of an upper molar. The other jaw is wider for the buccal surface. However, these clamps are also the ones I use for lower molars. The last clamp is the 8A. It's a deep-reaching clamp that allows us to grab teeth with little coronal height. I prefer using the Nygaard Ostby rubber dam frame as opposed to the Young's frame. It creates a better seal around the patient's mouth, it more effectively pulls their lips away from the operative field, and it is more facile to use during intertreatment radiography. An alternative is to use the Handy Dam by Tulsa Dentsply. This procedure should take less than a minute. Once the assembly is placed on the tooth, I floss the dam between the contacts if possible. Sometimes that is impossible, especially when a bridge abutment is being isolated. In those cases, seal around the isolated tooth with ultra-dense blockout resin. Simply syringe it around the edges of the dam and light cure it for 10 seconds. This will create a seal that is impervious to saliva and will keep the irrigating solutions from a patient's mouth.
Cutting access cavities in teeth is truly a difficult procedure to do well. If you undercut the opening, you will risk file breakage or worse, miss a canal, which will cause certain failure regardless of how well you treat the other canals. If you overcut the prep, you've increased your chances of perforating the tooth, causing its immediate loss, or you will simply set the stage for mid or long-term failure due to vertical fracture. Beyond these issues, the quality of the access cavity you cut will greatly influence the experience you will have throughout the rest of the procedure. When you cheat the access procedure, you will pay the price through the rest of the case. If the access preparation is done ideally, the rest of the procedure can be done with much less effort.
Access in maxillary anterior teeth begins with a number 2 surgical length carbide round burr. Do not use a number 4 round burr in anteriors and premolars. It's too big for those teeth. I'm going to start by making a cingulum to incisal cut. I want it centered mesial to distal in the tooth, coming from the middle of the cingulum to just shy of the incisal edge so I don't cause an aesthetic compromise. Just after I get through the enamel or the cast restoration, I'm going to take a very close look and make sure I like the position and the direction of the access beginning. This helps me easily correct at the start of the procedure, and because of that initial check, I can usually hit the pulp chamber the first or second cut after that. In anterior teeth, be certain to look for the pulp chamber under the cingulum rather than in the buccal direction. Most access perforations in anterior teeth are cut through the buccal surface, so if you have any doubts about buccal to lingual direction in a calcified anterior tooth, head more to the lingual. As soon as I enter the pulp chamber, I'm going to put the round burr away and complete my access with the LA Access diamond burr, as round burrs make irregular access cavity walls and generally overcut the preparation. The LA diamond burr is pushed into the pulp chamber, is rotated to cut just shy of the incisal edge, is pushed into the canal in the long axis of the tooth, and is then tipped back into the cingulum. Notice that in the first 15-second cut, we have completed nearly 85% of the access preparation. Classic anterior outline forms recommended in most textbooks show triangular shapes to cut tooth structure coronal to the common mesial and distal horns of these pulp chambers. But I think this is a needless waste of good tooth structure. Instead, if these pulp horns are present in the tooth I am entering, I cut a slot-like outline form as previously described, and then unroof these pulp horns by holding the burr or ultrasonic tip at an angle, thereby beveling off the pulp chamber roof coronal to the horns. Round-ended ultrasonics like the Buck one made by Spartan Obtura Company are exceptional for this. This ensures that I don't leave any tissue remnants and don't run the risk of having any darkening of the tooth after the endodontic treatment is completed, but retains the maximal structural integrity of the tooth. In mandibular anterior teeth, I'm going to create the same access outline form as I do in maxillary anteriors. I start with a number 2 round burr, being especially careful to limit the mesial to distal enlargement due to the narrowness of these teeth. Again, I cut halfway into the cingulum and shy of the incisal edge. Be careful to keep the preparation very shallow at the incisal extent. Here's the LA Access diamond burr. I'm not going to move it side to side, only in a buccal to lingual direction. I enter the pulp chamber with a pilot tip, rotate it up short of the incisal edge, drop it into the canal if possible, and then tip the burr into the cingulum. It's critical that you cut adequately under the cingulum because these teeth often have 2 canals. You can see that I have 1.25 to 1.5 millimeter access width. If you have less width than that, you are going to have difficulties during obturation. More than 1.5 millimeters and the tooth will be unnecessarily weakened. When completed, the access preparation should allow a file to be placed in the canal and stand relatively straight and unflexed as it exits near the incisal edge to accept rotary instruments without undue cyclic fatigue. The design objectives for posterior teeth are fundamentally different than those for the anterior teeth because the occlusal surfaces of posterior teeth are not centered over the root structure, but are skewed to the buccal on upper teeth and the lingual on lower teeth. While it may seem logical to center the access cavity in the occlusal table, this will inevitably result in over-preparation on the idling cusp side and under-preparation on the working cusp side. Therefore, the objectives that I set for my access cavities and posterior teeth are to cut right up to the working cusps and to stop short of idling cusps by 1 to 2 millimeters. Obviously, in bell-shaped coronal structures seen in some second molars and many third molars, it may be necessary to cut the preparation to both working as well as idling cusps. Premolars may have 1, 2, or sometimes 3 canals. When they have 1 or 2 canals, I cut slot-like outline forms. While many textbooks recommend round access preparations for single canal premolars, I disagree as this does not take into account the ovoid shape of their pulp chambers and the significant buccal and lingual fins projecting off the primary canal. When it is discovered that a premolar being treated has 3 canals, and I hate those teeth, the access cavity must be enlarged at the buccal extent toward the mesial buccal and distal buccal line angles to allow entry and treatment of the MB and DB canals, therefore resulting in a more triangular outline form. Just like in anterior teeth, the line angle extension of the access cavity should allow straight, unimpeded entry paths for rotary files to avoid premature breakage due to cyclic fatigue. Using a number 2 round burr, a number 4 is too big, maxillary premolar access preparations are begun in a straight line between the cusp tips, at the angle of the long axis of the tooth. Because the working cusps on upper posterior teeth are on the palatal side, I'm going to cut to that full extent in the buccal to lingual plane. As soon as I get through the enamel, I take a good look and I see that my initial preparation is off center. I'm a little too far to the mesial at the buccal extent. Because I checked this early on, I can still make a small correction here and find the pulp chamber without wasting tooth structure. That looks good. Now I'm headed for the pulp chamber. As I said before, this initial check seems like a small thing, but it makes all the difference. I spent years heading to the center of the tooth before checking my position and direction, making it all the more difficult to correct when necessary. I penetrated into the pulp chamber over the two pulp horns. I'm going to drop the tip of the LA diamond burr into one of those and cut off the remainder of the pulp chamber roof between. Again, I move the burr back and forth, keeping the mesial to distal enlargement minimal at this point. The pilot tip glides along the pulp chamber wall, defining the ideal access form. I end up with an ideal mesial to distal dimension just from the width of the burr. The buccal to lingual dimension is accomplished by dropping the pilot tip of the LA burr into each of the orifices and tipping it to those appropriate extents. Now, in very little time, I've created a smooth, continuous access form from the occlusal surface directly into each canal. I'm always interested to see what's in between the two canals in the isthmus area, and cutting a little deeper will aid the work of my irrigants in cleaning things out. Usually, if I take a round-ended Spartan Buck 1 or 1A ultrasonic tip and cut a bit down into it, I can find what is in essence the pulp chamber floor. Nice. This is really ideal, and it took less than a minute. Note how the files are standing out of the access cavity, skewed in relation to the occlusal surface, but centered relative to the buccal and lingual surfaces of the tooth structure. As is typical, the idling buccal cusp is nearly even with the buccal surface, and the abraded lingual cusp is 1/3 of the way in from the lingual surface. Access in a maxillary molar begins with a number 4 round burr. A number 2 is too small, and a number 6 is too big. This access begins in a straight line between the mesiobuccal and palatal cusps, but is at the angle of the mesial surface of the tooth. This is critical. Do not head in at right angles to the occlusal surface. At the least, a large ledge will be created at the base of the mesial access cavity wall, and at worst, it is possible to cause a mesial perforation. To figure this angle out, take a look at the straight-on pre-op radiograph. Also, set your burr up against the mesial tooth surface, get a finger rest, and then start by cutting a slot between the mesiobuccal and palatal cusp tips at that angle. Once I pass through the enamel, I'm going to check very carefully to see if I like the position and the direction of this initial burr cut, so I can correct any error without consequence. We see that it is parallel to the mesial surface of the tooth, and the angle looks good. I'm up to the working palatal cusp tip. I'm 1 millimeter or 2 away from the idling mesiobuccal cusp tip. Ideal. And now my next objective is to cut at that position and angle until I drop into the pulp chamber with the round burr. Classically, round burrs have been used to unroof the pulp chamber of molars, but I highly recommend against this practice, as it inevitably results in overenlargement as well as rough, irregular access walls. As soon as the round burr drops into the pulp chamber, its use is over, as the LAX diamond burr is not only capable of finishing the preparation, but is more suited to this purpose. The LA Access diamond burr has a non-cutting end like many other access burrs, but it is unique in its radiused projected pilot tip as well as in its small tip diameter. The other safe-ended access burrs with large tip diameters cannot penetrate into small canal orifices, leaving a ledge at the orifice that requires further refinement with another instrument. In addition, the LA diamond burr's small extended tip geometry acts as a gimbal around which the burr can be rotated to extend the line angle of the access cavity from the orifice level to the cavos surface in one efficient movement. In anterior teeth, this translates into rapid development of ideal access form. The LAX burr works better with the water spray on, but this is an extracted tooth demonstration, so you will see it used dry. But in practice, I always have the water spray on for several reasons. First, my burrs cut faster, they last longer, the tooth structure is less likely to have microfractures afterwards, and finally, I don't really need to see what the tip of the burrs are doing because the tip guides it around the pulp chamber periphery. This is how close I am to final access form in my first burr cut. It took about 15 or 20 seconds, and all that remains is putting the burr tip into the distal buccal orifice, tipping it up into the palatal orifice, maybe dropping into the palatal canal a little bit, gimbling it up to that cusp tip. See how I am coming in at an angle, getting into the orifice, how I cut into the canal a bit, and then tip the burr up to the cavo outline form I've already cut. This makes a smooth, continuous line angle extension from the occlusal surface to the canal itself. Now I am extending the mesial wall back, flattening it in preparation to look for the MB2 canal. After the outline form and line angle extensions are completed, I'm done with the LA access burr. If I have any challenges, any rough surfaces, if I have any buccal, lingual, or distal pulp horns, any further work is done with a round-ended Spartan Buck 1 ultrasonic tip. You can see I'm cutting out a trough in a straight line from the MB1 orifice towards the palatal orifice to look for the MB2 canal. The advantage of using a round-ended versus a sharp-ended ultrasonic tip here is that I'm not going to make a groove in the pulp chamber floor, which actually can mimic an MB isthmus. When these grooves gather dentin dust, they can confuse a clinician into following this pseudo-isthmus into the furcational area. Now remember that these MB1 and MB2 canals often curve as they come into the pulp chamber, sometimes by as much as 45 degrees. So when you reach the pulp chamber floor and start looking for MB2s, do not look further apically. You need to look for them in a mesial apical direction. I've cut at that angle and am now directed into the mesial canals. This is the Buck 2 ultrasonic tip by Spartan. I call it the floor sander. This in-cutting tip is going to help me flatten the pulp chamber floor. Very helpful in removing attached denticles. It's also going to unify the dentin color of the pulp chamber floor. Pulp chamber floor color is a big tip-off as to whether you've gotten rid of all the attached pulp stones, as well as indicating where to look for calcified canals. Pulp chamber floors and molars are typically a grayish-yellow color, and calcified dentin is a whiter color. Here's the final test. Can I put a file in each line angle at the cavo surface, then smoothly and continuously drop into each of the canals? Notice how this access cavity does not go distal to the buccal groove. That's unnecessary. The mesial wall at the cavo surface has been cut to within 2.5 millimeters of the mesial surface of the tooth, so the entry into the mesial canals is possible. The palatal line angle of the preparation is cut to that cusp tip, and the mesial buccal line angle is held 1 to 2 millimeters shy, and the distal buccal line angle ends up right about at the central fossa of the occlusal surface. The final access example is done on a mandibular molar. Access preps and mandibular molars are initiated with a number 4 round burr, but the initial access direction on lower molars is the opposite of maxillary molars. These accesses are begun in a distal mesial direction, and I typically put the number 4 round burr in the central fossa of the occlusal surface and cut toward the mesial. I use the same landmark for the mesial wall position as upper molars, about 2.5 millimeters distal to the mesial surface of the tooth. Again, I must make sure that my round burr is angled parallel to the mesial surface of the tooth. I do not head into the tooth at a right angle to the occlusal surface, or I will ledge the mesial wall, or worse, perforate it. So let's watch this access develop. I'm going to make a burr cut through the enamel and then check it, as with the other demonstrations. I want to stop the distal extent of this access to be no more than a millimeter past the buccal groove. You see here in the mirror, I'm a little shy of the mesial extent, and I don't want to take it any further in the distal direction, but I am centered buccal to lingual in the tooth structure. This means that I am closer to the buccal working cusps than the lingual idling cusps. After making this check, I should be able to enter into the pulp chamber in the next move. You can see here that there is a very tactile sense when I drop through the pulp chamber roof. This finishes the round burr's work. It's time to bring in the LAX diamond burr. We can see the LAX diamond burr dropping into the distal canal, righting the pulp chamber floor. Now it's cutting to the mesial, closer to the buccal cusps because they are the working cusps of lower molars. Now the LAX burr at the mesial angle of the tooth is defining the mesial extent of the access cavity as its pilot tip guides the cutting surfaces along the periphery of that part of the pulp chamber. As usual, the first LAX burr cut accomplishes 80 to 90% of the final access form. If the mesial orifices are big enough, I can enter them with the LA diamond burr placed at the angle the canal enters into the pulp chamber, allowing me to drop into each of them a millimeter or two, followed by rotating them up to the line angle extension at the cavo surface. If the canal orifices are too small to allow the 0.2 millimeter pilot tip in, then I'm going to open the orifices up with a number 15 K-file and/or a Spartan Buck 1 ultrasonic tip. I usually use ultrasonic access tips dry because I need to see where they are working. When the mesial orifices are big enough, I come back in with an LAX burr because that's going to create the smoothest, most funneled form into each of the orifices. What we see now is the Buck 1 ultrasonic tip being taken in to bevel off the pulp chamber roof of the buccal pulp horn. Again, although it is still taught that we should cut the access cavity to the full lateral extent of these pulp horns, this needlessly wastes tooth structure. Because we've already achieved the functional requirements of file path creation, having smooth, straight entry into each of the canals, we've reduced the chances of breaking our rotary instruments. So there's no functional requirement for cutting all this nice tooth structure coronal to these buccal and lingual pulp horns. You cannot use a sharp-tipped ultrasonic device for this function. Look at how big the lingual pulp horn is. Again, when we leave the nice tooth structure coronal to this area, we create an excellent undercut that's going to help lock in our post-endodontic buildup. Regardless of what some bonding guys say, you're always better having mechanical undercuts as well as chemical adhesion holding the restoration in place. This is a Spartan Buck 1A ultrasonic tip. It has the same round-ended tip geometry but half the diameter of the Buck 1, and is typically used to cut out the isthmus areas between canals and mesial roots of lower molars. This is especially important to do in retreat cases. Here's the final test. Can I put a file in each line angle at the cavo surface, then smoothly and continuously drop into each of the canals? We've achieved that outcome. Excellent.
Despite the advances in other procedural aspects of endodontics, negotiating root canals is still an art form. Like it or not, if you can't consistently get to the ends of root canals, it really doesn't matter what procedures you do thereafter. However, if you use a lubricant during negotiation, you can avoid pulp tissue blockage. If you start the process by taking tiny instruments through the end of the canal, you can keep the canal patent throughout the procedure. And if you use an apex locator during this negotiating process, you're going to know right where the root canal ends. By sticking to these three negotiating requirements, you will be able to sneak your way to the ends of root canal systems and own them. When you can achieve that outcome consistently, endodontics will become endlessly satisfying and you'll be practicing the art of endodontics. So let's see how to make it happen.
There are many brands of lubricants. The brand you choose to use is less important than the fact that you use a lubricant during all negotiation procedures. I like ProLube by Tulsa Dentsply because it has a single dose dispenser. Simply clipping off the tip allows us to fill a molar access cavity 4 or 5 times, usually getting us to the end of the negotiating procedure before we need to get a new tube. In large teeth, typically a number 10 K-file is the first instrument taken into place. These are extracted teeth, but in a real case, I would use an apex locator with each negotiating instrument, taking it to the point on the display of the Merida Root ZX where it indicates a ½ millimeter short. That is where the file tip is at the junction of the internal and external surfaces of the tooth. Notice in this microscopic end view how small the number 15 file is compared to the apical diameter of the terminus of the canal. When using an apex locator in this situation, you will typically get an irregular signal until you get to larger files which come closer to binding that apical diameter. Even a number 25 K-file is quite a bit smaller than that apical size. So we have a 19.5 millimeter length from the canal terminus to the reference point. In this case, we've started with a number 10, but we had to go to a number 25 to get a file to bind at length. You may either choose to take a radiograph with the 25 in place, or if you're using safe-ended files, you may choose to accept the very accurate length shown by the apex locator and move right into the shaping phase of treatment. In small roots, such as those of lower anterior teeth, we're always going to start apical negotiation procedures with a number 08 K-file. A number 10 is too large. If you move into the apical third of these canals with a number 10 or larger, you could easily block yourself out with vital pulp tissue. With coronally constricted canals, a file is placed to its binding point with apical pressure. A back and forth watch winding motion, moving through less than 90 degrees of rotation, is used until it tightens up in the canal. Then 3 or 4 pull strokes are used to loosen the file, after which apical pressure is returned to the instrument, it is watch wound again, and hopefully it drops further into the root canal. Once length has been achieved with the 08K file, as confirmed by the apex locator, the stop is adjusted to the reference point. I measure it and find that it's a long root, 24.5 millimeters. I try to read to quarter millimeter increments. Here comes a number 10. It's a small size jump from the 08 to the 10 file size, so when an 08 gets to length, usually a 10 will go there as well. Once these instruments are moved to length, we must take them a millimeter long to ensure that the end of the canal is patent or open, and then we rotate these files back to length as indicated by the apex locator. Let's see what happens with a number 15 file. Quite often in small roots, going from the 10 to the 15 is problematic. There are a lot of different workarounds to this challenge. Some clinicians say to work the 08 and 10K files in 40 or 50 push-pull strokes. Some clinicians use a half size, a 12.5K file between the numbers 10 and 15. While these procedural strategies may work eventually, I've found it simpler and quicker instead to do step-back enlargement with a number 20 and 25K file in a balanced force technique. In this case, after using just a number 20 file in a couple of cutting motions, I've created enough shape in the coronal 7/8 of the canal to allow the number 15 to easily and passively achieve length. When a number 15 exhibits tight resistance to apical placement, it is almost always binding in the coronal 7/8, which explains why using just 1 or 2 larger files allows the previously bulky file to achieve the intended length in such a canal. Multi-rooted premolars are classified as small root structures. We're going to start with a number 08K file. Unfortunately, an impediment has been encountered. The file is loose in the canal. It is not advancing further, so I'm going to put a little bend on the file with an endo bender plier. I make sure the teardrop stop that I put on this negotiating instrument is pointing toward the bend in the file, and I'm going to go in and hunt for a way around the impediment. I'm going to visualize what that file tip is doing and look for a passive canal path with which I can take it to length. I move it in with a certain direction, and if I meet the impediment again, I pull it slightly back out, turn it in a slightly different direction, and move the file apically again. Oh good, I've got a little sticky feeling there. That's what I'm looking for. I'm going to pick into the canal path where I got a little catch. The sticky portion of the canal means the file is back in the center of the canal instead of engaging an impediment with the file tip. I watch wind the file in that position, and as I look at the teardrop stop and see which direction the bent file tip was in when I danced past the impediment, I have now mapped the canal path irregularity, and I don't need to hunt for it anymore. I'm literally going to put the bent file in and go in that previously determined direction. In this case, I have to move the bent file tip in a buccal direction to bypass the impediment. Okay, I've got an 08 to length. Awesome. Of course, in a clinical case, I would then use an apex locator to confirm this length. I measure it, and this is my initial negotiating length, 19.25 millimeters. After I've confirmed that I can take a bent file to length, I take a straight number 10 file in to see if the impediment is still there. So obviously, if the canal form is past the number 10 file test, I'm going to put an unbent 15 file in. Now, a little bit of watch winding. Apical progress is made, but it's resisting placement to full length. Instead of overworking an 08, a 10, or a 15 file, I'm going to do the balanced force technique with a number 20K file. I ensure patency after the use of the larger file and will now watch how, with no serious work, the number 15 file drops to length with a watch winding pull motion. And I'm to length. The file went long, and then I rotated it back in a vernier movement, which would be done with an apex locator in place, followed by setting the stop to the reference point. And once we get a number 15 or larger to length, we consider the canal to be negotiated and ready for rotary instrumentation. Negotiating a mandibular molar. As usual, I'm going to fill the access cavity with a lubricant. I'm going to start in one of the mesial canals. It's a small root, so I'm going to start with a number 08K file. This is the mesiolingual canal, I believe. I use a watch wind pull motion, and I've been able to achieve patency. That was easy. I back it up to full length in the canal, measure it, and see that it is 21.5 millimeters. I want you to notice that quite often we lose 1/4 of a millimeter just between the 08 and 15K files. In most canals, if the 08 goes to length, a 10 will usually go as well. But let's see what happens with a 15. This is often the most challenging instrument to get to length during negotiation of small canals. You know, this is not meeting very much resistance. Let's see if it's going to go. Without horsing it in, it doesn't want to go, so I'm going to use the number 20K file with a balance force movement. If I use a larger instrument to make more shape, I need to be careful about leaving debris at the end of the canal where it could be compacted by an instrument with a tip size that is close to the apical diameter of the canal. So I'm always going to clear the end of the canal with a small file that will passively move through the terminus. Notice how the number 15 that was previously hanging up a millimeter short now passively drops to length. Just smoothing the canal path has shortened that canal length by 1/4 of a millimeter. Now for the other mesial canal with an 08 file. It looks like it's getting close. Push on it, watch wind, and it gets tight. Pull, watch wind, and there we go. You can often, especially in necrotic cases, feel the file tip drop past the terminus as you achieve patency. Okay, we've got 21.75 millimeters. I stick the number 10 in. So what you're seeing is a negotiating technique that's very consistent and predictable, and all the extra steps have been eliminated. We're not coating each file with a lubricant, we're filling the access cavities so they're all automatically coated. I've not started with an 06, and 08 will almost always move to length in small roots. We're not starting with an 08 in medium or large roots because it's unnecessary. If we can't get the 15 in place, we'll use a 20 and or a 25 with a balanced force technique. Then after getting patent with a 10, I bring the 15 back in and find it drops easily to length and with control. Again, we lost 1/4 of a millimeter during that negotiating procedure. Here we are on the distal root. The number 10 easily went to length. So nice to have an easy canal shape, an easy canal negotiation process, and at this point the 10, 15, and 20 have easily gone to length. The apex locator would tell me that I'm long, and I would rotate the file back into that 1/2 millimeter position on the meter display, and measuring it, it reads 23 millimeters to the mesial marginal ridge as reference point. First, I fill up the access cavity with a lubricant. My access cavity prep allows me to drop each of my files effortlessly into each of the orifices. The MB1 is a small canal, so it's begun with an 08K file. I have tight resistance to apical file placement. I use watch wind pull motions, loosening up the instrument, and allow it to traverse more deeply, but I'm meeting increasing resistance. So instead of overworking the 08, I'm going to use the number 10 without attempting to get it to the same depth. I just want to open up the coronal 7/8 of the canal a bit. I'll even bring in a number 15, especially when I know I have a lot of canal curvature. I want to bring in the 08K file again with a bend on it because I felt an impediment. The instrument is now more easily placed, and check it out. Using a lubricant, putting a bend on the file, creating a little bit of coronal enlargement with the 10 and 15 instruments allowed my file to glide around the S-curve, and with the teardrop stop, I have now mapped the canal curvature. I will no longer have to hunt for the canal path. I simply put my pre-bent file into the canal in a mesial direction, then in a distal direction, and then again in a mesial direction to get to length. Now I have a bent number 10 file taking the same path as the 08 all the way to length, which is typical after an 08 goes. I do a little push-pull filing to loosen it up, and then the number 10 usually will go as well. I have an 18 millimeter length in this canal. Here's the number 15. I really don't expect it to go to length. It's a big jump in size from the 10 to 15, especially when I'm in a canal with severe curvatures. What I'm really looking forward to is creating a little bit of shape with this instrument. It's bent. I want to make a little bit more shape using the balance force technique with the number 20, being certain not to take to the same length. Now here's the 10, assuring patency, making sure there's no debris collected at the end of the root canal to compact with the number 15 file. And when I take it back in, it's bent. I made more room with the number 20. Now for the distal buccal canal. Watch wind and pull motions. It's a small root, so I'm going to start with an 08K file. Initially, I'm feeling tight resistance to apical file placement, and when it doesn't go, I use the number 10 and the number 15 shy of that length. Then the 08 penetrates further into the canal. Again, I'm advancing further apically with the 08K file, and in this case, it still feels tight. This is unusual, so I resort to taking in an 06K file with a little threading motion to see if I can gain further apical depth. 06K files are typically unnecessary in canals unless they are really tortuous. These tortuous canals do tend to narrow around these curvatures for some developmental reason, and cool, the 06 is taking a length. So now I'm going to work the 08, and we see the file coming out the terminus. This gives me a really happy feeling. The moment that you get patent in a canal with that first file, the chances of successfully treating that canal have dramatically improved.
With so many endodontic file designs available, it's difficult to know which file set is best for you and your patients. The most important factors to look for when making this choice are safety, consistency of results, a proven success rate, and last but not least, efficiency. The ideal file design is system-based, meaning that there are filling and restorative materials that are perfectly compatible with the shapes that the file set creates. In addition, the file system you choose must address the full range of root canal anatomy that you will encounter in practice. The ideal file system can create consistently ideal shaping outcomes with the least number of instruments and steps. In this section, I will describe the features of the GT system and explain how they address these important requirements.
First, let's see a shaping procedure done on a straight canal with a large apical diameter. We're going to start by irrigating with sodium hypochlorite, and as usual, we are going to start with a 2010 GT file. As soon as it stalls, we take it out, look at the flutes, and clean them off. Most of these files are used twice before we go down to a smaller taper. You can see as we approach the terminus, the apical progress slows. We are going to drop to a 2008 because that's going to more easily get to length. We look at the flutes, and there is no debris at the ends of the flutes, so I'm guessing that this canal terminus is larger than a 20, but let's go ahead and irrigate with EDTA to start removing the smeared layer before gauging. We confirm patency with a number 15K file, and here's the NITI number 20K file. For gauging, it slips through, so the terminal diameter is larger than 0.2 millimeters. Next, the number 30 slightly slips through also, so obviously it's larger than 0.3 millimeters. Here's the number 40, and it's stepping back a half to 3/4 of a millimeter short. So the next logical move is to cut a 3010 GT file to length. Again, we have the correct settings on the Aseptico DTC motor so that we have the right RPM and torque limit. I'm not quite to length. I'll clean the file and hopefully cut to length in the next move. And there we go. Let's look at the tip flutes and see if we've cut debris all the way to the end of the root canal. In fact, we have not. There is no debris at the file tip flutes, so I'm going to take a 4010 in. Notice that this file has a larger shank diameter. We see the torque limiter backing the instrument up. It's no big deal. I don't have to take my foot off the pedal or pull the file out. I just lighten the apical pressure on the handpiece and let the file continue to cut. There's quite a bit more debris, but it's getting dry and would have been a little bit better if I had added some irrigant. And despite a parallax error, I'm at length. Now we look at the tip flute, and in this close-up view we see debris in the very last flute, so it is likely to gauge at a 40. I irrigate with EDTA solution to remove the smeared layer as I finish this procedure. Now the number 30 drops through, and here's the 40 binding right at length. I can tap on it as long as I don't rotate it, and we're done. This ideal shaping result is confirmed by the very tight cone fit at the canal terminus. After cone fitting, I'm going to continue irrigating with sodium hypochlorite to continue cleaning the canal. Next, we'll see a straight canal with a small apical diameter shaped. Again, I start by irrigating with sodium hypochlorite, And again, I start with a 2010 GT file. I'm making relatively slow progress because this is a small canal. As soon as the file stalls, meaning that it's rotating in place and not moving apically, I pull it out, clean it, and put the file right back in. Now I'm making slower apical progress as I approach the terminus. And after 2 uses, I'm going to drop down to a 2008. It is stalled, so I take it out and clean it with an alcohol gauze turned in a counterclockwise direction. After replacing the 2008 into the canal, it doesn't look like it's going to get to length, so I'll use the 2006 next. Here's the 2006. Notice how much easier I'm able to cut to length by dropping down in taper size. We're always better off taking the less aggressive path. Dropping down in size, we also see the debris at the end of the last flutes of this file, so it's possible we're finished with this shape. I irrigate with EDTA solution so that I can simultaneously remove the smeared layer as I gauge the canal. The number 15K file drops through the terminus, confirming patency. And now the 20K file binds at length, proving we have apical continuity of taper. Let's put the 30 in and see what happens. Nice. It steps back, confirming that I have apical continuity of taper. After seeing that a number 30 steps back about 1.5 to 2 millimeters, I clear with the number 15 again. The apical cone fit, exhibiting tightness of the canal around the tip of the cone, confirms that there is apical continuity of taper and the accuracy of our gauging result. After cone fitting in the presence of EDTA solution, we are going to switch to sodium hypochlorite because the canal needs further cleaning before the fill is accomplished. The following is a molar shaping routine. We're going to shape mesial canals of this lower molar followed by the distal canal. I start by irrigating with sodium hypochlorite as usual. And then the same file I always start with, a 2010. These canals are each the same lengths, so I'll shape them together. I use the 2010 twice in the buccal canal. Now I'm going to cut twice in the lingual canal. The first file placed usually makes excellent apical progress. The canal is bigger there and it's straighter there. Then as I approach the terminus, the apical cutting progress slows due to the narrow diameters and the greater curvatures encountered. Now I'm going to drop down to a 2008 GT file. Each of these instruments is used twice in a small root before I drop down in size. The 2008 GT file, nice cut. We're going to use it again, and it doesn't make much progress, but it is moving. Find a reference, such as the spring bow of the clamp, to see whether or not the file is continuing its apical progress. Even if it's moving slowly, I'll let it continue to cut with the same apical pressure. Nice. In the mesiolingual canal, I get to length with the 2008. I have debris at the tip, which indicates that the canal will probably gauge at a number 20. So I may have completed the shape here. Because I didn't get to full length with the 2008 in the mesiobuccal canal, I dropped down to a 2006 and achieve length without much debris at the tip. Now I irrigate with EDTA solution so I can remove the smeared layer as I finish the preparation. First, I clear the terminus with a patency instrument and then gauge. In the mesiolingual canal, as I expected, the number 20 NiTi K file binds at length and the number 30 binds short. After I gauge, I always clear with a patency file to make sure no debris was scraped off the canal wall during that movement. Here I am in the mesiobuccal canal. In this case, the number 20 binds at length also. I bring the 2008 back into the mesiobuccal canal, and this time, after the 2006 has been there, I am able to cut the 2008 to length. One more irrigation with EDTA, and I'm going to recheck the gauging result. The number 15 slides through, establishing patency. The number 20 binds at length. I'm done. I revert to sodium hypochlorite irrigant. Now I'll shape the distal canal. It's a medium root. So if I can, I'll cut the 2010 to length. This is a medium root, so that's appropriate. In the first cut, I'm within a couple millimeters of length. There is a parallax challenge here, so it's hard to see the stop as it meets the reference point, but I'm nearly at length after just 2 cuts. In medium and large roots, I get to length about 50 to 60% of the time with my first 2010 GT file. I can see debris in the last flute of this first GT file to length. Great. I irrigate with EDTA solution and clear with the number 15 through the terminus. The number 20 drops through and the number 30 binds at length, so I'm going to finish this shape with a 3010 GT file. And I'm at length. Let's look at the file tip close up. I have debris in the very tip flutes. My guess is that I'm going to find that the number 20 is still slipping through and that the number 30 binds at length, confirming that the shape is complete. In summary, when the gauging instrument that binds at length is the same tip diameter as the GT file that went to length, we're finished. We have a taper that goes all the way to the end of the root canal, the most important factor in apical accuracy during obturation. Next, I'm going to shape a small canal with severe canal curvatures requiring the use of a GT hand file. I start by irrigating with sodium hypochlorite, and then I bring in a 2010 GT rotary file. You can see the shank of the instrument with the color band indicating the ISO designation of the number 20 tip diameter, and the black taper rings, 5 rings times 2, indicates a 0.10 taper. In this case, due to the cervical curvature of the canal, the 2010 stalls almost immediately. There's no debris in the flutes, which tells me that this file met a curve in the coronal half of the canal that it did not want to go around. I immediately switch to a 2008. I don't get much of a cut with this file either, so I drop down to the 2006. In this case, I do see it walking into the canal, but not easily. I then drop to the 2004, and it stalls at a point 3/4 of a millimeter short. This is a tough, tortuous canal. I confirm patency with the number 15K file. You can see that it's got a bend in it to help it around the apical curve. I'm going to have to do a balance force enlargement of the end of the root canal with a number 20 NiTi K file. I've used a 2010, a 2008, a 2006, and a 2004 GT file in this initial crown down shaping routine. So if I don't get to length with even the 2004 GT rotary file, I use a size 2002, which is basically a K file geometry. So I've cut that to length. I confirm patency with the number 15 K file again, and now I'm going to try cutting that 2004 GT file to length again. After the number 20K file is cut to length, the tip of the 2004 will now act as a passive pilot guide, easing the file to length. We see it bump past the apical canal curvature, and good news. There is a bit of debris at the tip flutes. That's a good indication that the terminal diameter is 0.2 millimeters. This is such challenging anatomy, I wouldn't even consider bringing a rotary GT file in after this. Instead, I'm going to bring in a hand GT file. The white handle indicates an 0.6 taper in the current convention. And we use this in a reversed balance force technique because it's got reverse direction flutes. I rotate the file counterclockwise until it tightens in the canal, usually about 1/4 of a turn. Then I push on the instrument and rotate it a full 360 degrees, causing the cutting action to occur. After 3 to 5 cuts, I clean it off, put it back in. It's tight, I push on it, cut. It's tight, I push on it and cut. Again, it's tightened, I push on it and cut. Tightened, I push on it and cut. And I'm to length. This file has triangular blades with 60-degree flute edges, so they're very sharp, much sharper than a landed blade instrument. We see debris at the very tip of the flutes, telling me that I most likely have apical continuity of taper. Now I irrigate with EDTA solution so I can remove the smeared layer as I do the final gauging routine. Here's the number 15K file to clear the end of the root canal and assure patency. Here's the number 20 NiTi K file, binding at length, and I'm done. And the number 30 steps back quite a bit so the canal shape is confirmed. Whenever I gauge, I always clear with a patency file afterwards because debris can be scraped to the end of the root canal just by passively sliding the gauging instruments to length. I then irrigate with sodium hypochlorite to continue cleaning the canal after the shaping is done. Shaping a large canal with severe curvature. This palatal canal in the same tooth has a severe apical curvature, but it's got a big shape coronally, and in the first pass we see the file gets to length. And I have debris at the tip of the file. This is one of the most rapid shapes I've ever demonstrated. I have patency, exhibited with the number 15 file sliding through the terminus, and here's the number 20 NiTi K file, and sure enough, it binds at length. Here's the number 30, it binds short. So obviously I'm in a canal that already had a virtually perfect taper, although I probably idealized the taper in the apical third. It's a common myth that irrigating with tap water or anesthetic solution is as good as any other irrigant. This is simply not true. This SEM photo of a dental surface after irrigation with water illustrates the incredible layer of debris left in canal walls with this regimen. What we need to effectively clean root canal systems are two solutions proven since 1975, 6% sodium hypochlorite and 17% EDTA in aqueous solution. Sodium hypochlorite is more time dependent. It is necessary for sodium hypochlorite to be in the root canal system 20 to 40 minutes depending on whether it's a necrotic or vital case, while EDTA solution only requires 30 to 60 seconds to accomplish its objective. This is an SEM photo of a canal wall. The left side was instrumented, the right side was not instrumented, but both sides were irrigated with sodium hypochlorite. We see that the right side is remarkably clean, with pulp tissue ideally removed, leaving the natural calcospherite projections of uncut dental surfaces, but the left side is dirty. This is the smear layer resulting from abrasion of those surfaces by the root canal instruments. The next SEM photo shows both the instrumented as well as the uninstrumented surfaces, left and right respectively, after irrigation with both sodium hypochlorite and EDTA solutions. Both sides are clean. So it is a truism that files, while they cut dentin very effectively and grossly debride canals, do not actually clean those surfaces. It is the irrigants that clean the canal walls. Without the right irrigating solutions, in effective concentrations, and with sufficient time needed to do that project, we will not get the job done.
Three-dimensional obturation of the root canal system used to be difficult and time-consuming. With today's technology, it takes less time to fill a root canal system to its full apical and lateral extents than it does to do more traditional techniques that only fill primary canals. I'm going to show you how to do two different centered condensation techniques, both of them capable of filling complex root canal systems in seconds. The first will be the continuous wave of condensation technique using the System B Elements Obturation Unit. Secondly, I'll demonstrate carrier-based obturation using GT obturators. After seeing this, you will understand that methods that only obturate primary canals are truly outdated, third-world endodontic procedures. After seeing this, you will never again want to miss out on the thrill of the fill.
Obturation using GT carriers. There are several accuracy techniques that are critical to achieving excellent fills with carriers. First, I'm going to trim gutta percha off the end of the carrier to expose 1 millimeter or 1.5 millimeters, and then also take the surplus off the shank end. I measure the carrier 1 millimeter short from the full length of the canal. I dry the canal and apply sealer with a paper point. This is Kerr pulp canal sealer, and I mix it thinner for carrier fills than for continuous wave obturation. I apply it with a paper point to the end of the root canal, moving the paper point back and forth several times. Next, it's critical that excess sealer is blotted with the paper points. We see this paper point coated with sealer, indicating that sealer is still filling the lumen of the canal. Typically, it takes 2 to 4 paper points to blot the sealer until it appears to be spotted rather than coated with sealer. The carrier has been placed in the GT oven arm, hanging by the handle. Watch this animation showing how the carrier, trimmed short of gutta percha, moves through the canal slower than the sealer and gutta percha, thus ending up 1 millimeter short, while the sealer and gutta percha move ahead of it all the way to the end of the root canal. Switching back, as we watch the GT carrier, notice how it is placed slowly. Because GT carriers fit a GT canal shape more tightly than a thermofill carrier in a non-standardized canal prep, there's less of an escape vent between the carrier and the canal wall, making a 6 to 8 second insertion rate appropriate. Then I grab the handle, pull the stop up, and break the handle off so that I have more room to put carriers into other canals. Here's the buccal view of the distal canal I just filled. Pretty nondescript, but check out the mesial view. We see a normally hidden severe curvature and an apical bifurcation of the root canal space. Cut the GT carrier off at the orifice level with a number 4 preppy burr. In clinical practice, I would use this with water spray so that I can flash set the sticky gutta percha, making it much easier to clean out of the pulp chamber. We then use a solvent like chloroform or xylol to clean up the rest of the gutta percha debris from the pulp chamber. Carrier obturation of a canal with an impediment. The canal is dried with a GT paper point, having the same taper size as the GT file. The sealer mix, again for carrier filling, is thinner than cone fit fillings. Notice how it strings about 1/4 inch to 1/2 inch before it drops back to the pad. I coat a paper point and move it back and forth in the canal to coat it with sealer liberally. Then, as before, I'm going to blot the surplus sealer with paper points. If I don't do this, I'm going to have a huge blowout of sealer at the end of the root when the carrier squeegees it through the canal terminus. After I blot with several paper points, the next one is spotted with sealer, indicating that the sealer is no longer filling the lumen of the canal. Typically, I will trim the excess gutta percha off the carrier and have it heating in the oven as I dry the canal, apply the sealer, and blot the surplus. I've removed the excess gutta percha. I've set the stop to be 1 millimeter short of full canal length, in this case 19.5 millimeters for a 20.5 millimeter canal. The carrier has been heated, and now we see the slow, steady introduction. You can see the sealer is starting to move at the end of the canal. And we're there. That was a long, slow placement, but this was a narrow canal, so we don't want to hurry the placement of the carrier. Now pull the stop up, break the handle off. I'm ready for a radiograph. Check out the micro CT reconstruction showing the carrier 1 millimeter short of the end of the root canal, and as it rotates, we are going to show the gutta percha and sealer around it. We can see how the obturator filled a little bit of an apical irregularity and a little bit of a fin in the coronal third. Also notice the curvature of this canal. With the carrier in a position within the last millimeter of the canal, it's easy to see that we can create an exceptional condensation force there, much deeper than we can achieve with pluggers. Continuous wave obturation. Let's start with cone fitting, since this is a cone fit obturation technique. Cone fitting in GT shapes with GT cones is very simple, however it may be different than you're used to. The cones are sized by their tapers only, and they are all feather tipped at the end. You may want to use what's called a gutta gauge made by Dentsply Myofer. I insert the cone into the gutta gauge die corresponding to the apical size we have cut the shape to. I trim off the excess with a scalpel blade. Now this won't be my final adjustment, but this will get it very close. I then find the binding point of the cone in the wet canal. I use locking pliers to pinch a little mark at the end of the cone and then measure it. At 20 millimeters, I'm a 1/2 millimeter long of full length in the canal, so I cut 1 millimeter off because I want to end up a 1/2 millimeter short. The canal is 19.5 millimeters, therefore the cone is fit at 19 millimeters. When we look at the close-up apical view, we see that it's a perfect cone fit into the preparation. Also, we see confirmation of the excellent apical continuity of taper because the canal binds the tip of the fit cone all the way around its circumference. Cone fitting confluent canals. This is a less understood technique. We have mesial canals that are confluent in the apical third. Quite often we don't know whether canals in the same root are confluent until we have the canals fully shaped and it's time to cone fit. I fit a cone in the first canal, I pinch the cone at the reference length, measure it, cut it to be a 1/2 millimeter short, and I put it back into the canal. Notice that I'm fitting the never fit cones in a dry canal because you will get false tug back at a different length than the cone will go to when it has sealer lubricating it. Once I'm done with final adjustment of the cone, I cut the butt end off, indicating that the cone is ready for the fill. I trim off the feather ends of these cones prior to fitting them. If we use EDTA solution to remove the smear layer, if we have a cone that perfectly matches the shape of the canal, we should have a very crisp sensation of tug back. Cone fitting should be very fast and very straightforward. Measured, clipped until we are half a millimeter short of full length. I'm at 21 millimeters, so I had to trim an extra half millimeter off to make it at 20.5 millimeters. I put that cone back in, and now both canals have been fit to full length, finishing once again by cutting off the butt end, indicating the cones have been adjusted. Now I'm going to check for apical confluence. Here comes my second cone in the secondary canal. I know it fit all the way to length when it was in there by itself, but now we see how the cone in the mesial buccal canal will not go to length with the other cone in the mesial lingual canal. When I pull that cone out and the mesial buccal cone drops to length, that proves apical confluence. My favorite technique for fitting cones in this kind of canal anatomy is to very carefully grab what I call the secondary cone. I don't pinch it but measure it, which discloses the length from the reference to the point of confluence. Then with sharp scissors, I serially trim the cone back at an angle until I get tug back at that length. In this case, the point of confluence is only a couple of millimeters from the full length of the canal. And now I've got tug back. I measure to see if the cone is at the intended length or within a half millimeter. I grab the cone at right angles from the reference point and check it out. Here's a mesial view showing the secondary cone and the secondary canal joining the primary cone at the angle that the cone was clipped at. I'm now ready for downpacking as soon as I do plugger fitting. Continuous wave obturation with single cone backfill. This is a large rooted canal with a big shape, so I'm picking the largest plugger, a .12 taper. These electric heat pluggers are made from dead soft stainless steel, so I can put them in, push on them, wiggle them, and they will take the curve of the canal. I shorten the stop to the reference point, and then compare the fit plugger to the fit cone to make sure that it's not fitting too deep in the canal. This is especially important in large canals. I'm drawing the canal now that I've fit the cone and points to confirm the length as my final procedural nuance. The cone is now cemented into place with a thicker mix of Kerr pulp canal sealer. I use the same sealer for both carrier and continuous wave obturation. I shear the cones off at the orifices and then use the fat stainless steel end of the number 1 plugger to condense there. I'm condensing the softened gutta percha at that orifice level. I'm now ready with the cold electric heat plugger. I push on the button, and as I push on the rapidly heating plugger, it immediately drops towards the binding point. I then take my finger off the plugger switch prior to reaching the binding point. I'm now going to hold a sustained condensation force on the cooling plugger for 10 seconds, indicated by 2 clicks from the System B element system. I push apically after the 10-second double click. I rotate it to break the plugger loose from the condensed gutta percha, and after that occurs, I put a slight back pressure and rotate it back and forth to move it out, leaving all the gutta percha in the canal with a hole left there the size of the plugger. The next step is to prepare an auto-fit backfill cone, the exact same size as the continuous wave electric heat pluggers, to fill the space that was left. I clip a millimeter off the tip of the cone. I coat that backfill cone with sealer, place in the backfill space, sear it off at the orifice level, and condense one more time at that point. You do not want to backfill more coronally than the CEJ in anteriors or the pulp chamber orifices in molars and premolars. I'm still taking some gutta percha out. I want to have an etched and bonded material right down to the gingival level so that the chances of coronal leakage are minimized. Surplus gutta percha can be effectively cut off with a plugger. We want a flat, even interface so that we don't have any voids between the buildup and the coronal gutta percha. This micro CT scan shows a very dense fill. We have irregular apical anatomy that was easily sealed, and we're just about a millimeter to the CEJ. You can see how easy a one-cone backfill is, and that's what I do in almost all of my medium and large root cases. Continuous wave obturation with syringe backfill. In small roots, I'm usually going to be downpacking around curves, so a syringe backfill is usually necessary. This is a .06 plugger, and you can see that during plugger fitting, I push on it and wiggle it, which bends it so that it fits to a deeper binding length as shown in this animation. I adjust the stop on the fit plugger, compare it to the fit gutta-percha cone, to make sure I'm deep enough in the root. The canals are going to be dried with GT paper points. You can see the 3 rings on the shank end indicating an 06 taper. Here's an animation of the cone being cemented into the canal. The pre-fit plugger sears the cone off at the orifice, followed by the gutta-percha being condensed with a fat stainless steel end of the number 1 hand plugger. And here's the electric heat plugger driving through the master cone. I hold a 5-second sustained condensation force, fire a 1-second separation burst of heat, wait another second, and withdraw the plugger and the gutta-percha that's stuck to it. The small flexible niti end of the hand plugger is brought in to condense the apical mass of gutta-percha. So now I'm ready for the downpack. I don't have to blot the surplus sealer in this technique because in cone fit techniques, all the surplus is going to move coronally, unlike in carrier techniques, where it will move ahead of the carrier. The primary cone is cemented to the end of the root canal first, then the secondary cone is butted alongside of it, both of them with sealer on them. Each cone is seared off at an angle across the orifice level. The fat stainless steel end of the number 1 hand plugger is used to condense the coronal mass of gutta-percha at the orifice. This is going to be a quick downpack as the root is not very long. I downpack just slightly short of the binding point, holding a sustained condensation for 5 seconds. I then do a separation burst that lasts a full second, after which I pause for another second. I now bring in the narrow flexible niti into the hand plugger to condense the apical mass of gutta-percha. Now I'm ready to downpack the adjacent canal. I think, despite this very short downpack movement, you're going to be surprised by the extremely three-dimensional result. Again, I do a separation burst after 5 seconds of sustained condensation pressure. Now I use the narrow niti end of the hand plugger. Check out the post-op film. I filled a lateral canal and have pushed gutta-percha through the isthmus between the canals. Now I'm ready for the syringe backfill. In this animation, the needle goes into the canal after it's been primed, and very important, I hold it in the canal for at least 5 seconds before I hit the button. I hold the syringe into the canal, causing it to fill the space ahead of the needle, and then I let the extruded gutta-percha back the syringe needle out of the canal to the orifice level. Then I condense the material at that level. Let's watch the real deal now. Here's the syringe being primed. I put it in the canal to its binding point and count 1001, 1002, 1003, 1004, 1005. I hit the button. The gutta-percha comes up around the needle and backs the needle out to the orifice level. I finish by condensing with the stainless steel end at that level. During the backfill of the mesial canal, I've also pushed material into the mesial buccal canal through the isthmus. I condense at the orifice level, put the needle in the mesial buccal canal, wait for 5 seconds, and hit the button. The gutta-percha syringe needle backs out to the orifice level, and then I condense that material with the stainless steel end of the number 1 hand plugger. Careful condensation at the orifice level finishes the backfill. Void removal with downpack and single cone backfill. Occasionally, a void will be seen in the backfill. While it is aesthetically unpleasing, this kind of void is of no clinical consequence. However, I recommend that they be removed, a very simple procedure. Here's my electric heat plugger driving down. I've condensed to the level of the void, then I wait 10 seconds, and break the plugger loose. Do not heat the gutta percha again, as it will pull out and deform, setting you up for another backfilling void. And then back it out, leaving the gutta percha in the canal. Here comes a backfill cone with sealer on it. I sear the cone off at the orifice level. I condense right there, and the void in virtually every case will be gone. If you try and strip all the gutta percha out and backfill with a syringe again, you will frequently end up with another void afterwards. That's maddening. So here we go. I've downpacked with a .06 plugger to the level of the void in the mesiobuccal canal. I wait 10 seconds for the plugger to cool. I then push apically as I rotate the plugger, breaking it loose from the ideally condensed gutta percha, and then I tease it back out with a little bit of back pressure. Make sure you clean and straighten your plugger before you do this backfill procedure. Now there's a hole in the gutta percha exactly the size of the plugger. I use Analytic Technologies AutoFit backfill gutta percha cones. They're the same size as the plugger in each of the sizes. I coat it with sealer, throw it in the backfill space after I liberally move the sealer around. I'm going to then sear the cone off at the orifice level. Usually I try to hold the plugger at a 45-degree angle to accomplish this purpose. Don't rush this part of the procedure or you may pull the cone out. Here comes a fat stainless steel end of the number 1 hand plugger. I'm going to condense at the orifice level, and now let's see a radiograph to see if I've removed the void. Indeed, it's gone. And now I have an exceptional fill, including lateral canals in the apical thirds of both roots, and I filled the whole isthmus area with sealer and gutta percha. And here's the micro CT scan reconstruction of the distal root filled with a GT carrier and the mesial canals filled with the continuous wave technique. Both of these techniques are centered condensation procedures. They are both extremely three-dimensional, and they are both very effective and efficient to do.